Good afternoon. I think we're going to jump right into the pertussis vaccine section and introduction by Dr. Sawyer.
Thank you, John. I'm happy to introduce this afternoon's Pertussis Vaccines Working Group update. First, an acknowledgement of our work group members that you see here. I particularly appreciate the broad expertise of our liaison representatives and our invited consultants and the dedication of this group. A specific mention of Peter McIntyre, who you will hear from later. We have our work group calls at 2 or 3 p.m. Eastern Time, and Peter joins us from Australia. I will let you do the math, but that's very early in the morning. A special recognition of Jennifer Liang, our designated federal officer, who has supported us through a long list of deliberations, which you see here as the original terms of reference under which this version of the pertussis work group was constituted. We have completed all of the items in white and are just finishing up these last two major terms of reference, the biggest of which is to consolidate the 4 separate recommendations that are currently in existence that relate to different pertussis vaccines into a single statement, and we're looking forward to that being completed near the end of this year. And of course the topic for today, which is Tdap revaccination. A reminder that there are currently 2 licensed Tdap vaccines in the United States with slightly different compositions and slightly different age groups for their indications. Both of these licensed products are at this point indicated or licensed for a single dose of vaccine. And the current ACIP recommendations are for a single dose of Tdap vaccination in people of all ages, with particular emphasis on adolescents and 11 and 12 years of age. The further guidance on forthcoming revaccination is what the topic of today's discussion is about, and the only exception to this is our recent recommendation published this February that pregnant women should receive a repeat Tdap vaccination with every pregnancy. There's a decennial TD booster recommended for those who, after they've received their single dose of Tdap, with the exception of accelerated use of TD in wound management situations. There are ongoing this is a summary of ongoing safety activities that relate to the recent maternal Tdap recommendation. The Vaccine Adverse Event Reporting System is undergoing ongoing monitoring of pregnant women who receive not only first but repeat doses of Tdap. The Vaccine Safety Data Link is looking at coverage data, and I'll share a quick summary of that, and have initiated further safety studies to continue to evaluate this. And the Clinical Immunization Safety Assessment Group has some potential targeted studies under discussion. Here is that preliminary Tdap coverage rate during pregnancy. This is from the Vaccine Safety Data Link and provided by the Immunization Safety Office. This covers the years of 2007 through 2011. And in summary, at this point, still a relatively small percentage of pregnant women have received Tdap during pregnancy. Overall, 6.1% during those years, and 7.2% of those pregnancies that ended in live birth. Much of this data is driven by the California numbers, which beginning in 2010 in response to our very large pertussis outbreak at that time, the California State Department of Health recommended vaccination during pregnancy, and this was initiated in a number of provider offices during 2010, such that the 2011 data for California, as you see, we had achieved a coverage rate of 29% of pregnant women during pregnancy receiving vaccine. If you subtract California from the VSD sites altogether, the remainder of the sites were only at 1.6% for 2011. And all of this data is yet to reflect the newer recommendations made nationally from this group that all pregnant women begin to get vaccinated during pregnancy. We do expect that in the fall of 2013, some of that data will begin to be available to let us know how those new recommendations are taking hold. So why are we addressing Tdap revaccination today? Well, clearly at this meeting we've heard a number of presentations in past sessions about the increasing burden of pertussis in the United States. Tdap vaccine was first recommended in 2005 with the decennial TD recommendation to follow, as I've already mentioned. It has now been almost 10 years since Tdap was first recommended, and so it's timely to look at whether what role Tdap would play in revaccination settings. And we now have growing data about the effectiveness and immunogenicity of second doses and first doses of Tdap, much of which will be reviewed today. A reminder of what we covered in the February meeting. We had a review of the resurgence of pertussis with an update on the national epidemiology. We had evidence of the effect of protection in adolescent populations and the lack of evidence for a herd impact of that vaccination campaign, which has been underway for a number of years. And we began to review the data on Tdap effectiveness and waning immunity. And we presented some options to this group at that time about what to consider for second doses of Tdap, and we're guided to investigate further a second dose as opposed to just multiple doses. So the discussion we're going to have today is a number of analyses that relate to this guidance from ACIP about a second dose of Tdap and to whom that might be recommended. So to summarize today's session, we'll hear from Dr. Anna Acosta with an update on pertussis epidemiology and vaccine effectiveness. Jennifer Liang will then talk about antibody persistence, safety, and immunogenicity. Dr. Hajime Kamiya will present us our decision and cost effectiveness analysis that the work group has considered. Jennifer will lead us through a discussion of the work group conclusions from that data and a discussion from the ACIP today. And then we have the great fortune of two presentations from abroad with the effectiveness of maternal Tdap programs in Australia and United Kingdom, the first by Peter McIntyre, the second by David Salisbury, and then we will complete the discussion. And just as a reminder, these were the scenarios we presented to you at the February meeting for consideration of when and how a second dose of Tdap might be considered. The current recommendation at the top, scenario number 1, at which we considered a repeat vaccination of adolescents at 16 years of age, followed by TD vaccinations thereafter, or scenario number 2, in which we gave a second Tdap vaccination 10 years after the first, starting at age 21. So this has framed a lot of the discussion of the work group since the February meeting, and it was integral in the cost effectiveness analysis that you will hear soon. So with that, I'd like to bring Dr. Anna Acosta to the podium for her presentation.
Good afternoon. Although there has been a dramatic decrease in the number of reported pertussis cases with the advent of the vaccination program, pertussis remains endemic in the U.S. There have been substantial increases in the number of pertussis cases recently, especially in 2010 and 2012. More than 48,000 cases have been reported for 2012, with counts still coming in. This is the most number of cases since 1955. For 2013, there have been close to 7,000 pertussis cases reported in the U.S. This is less than half the amount reported for the same time period in 2012. Despite the overall decrease in the number of pertussis cases thus far, some states are reporting increases over their 2012 numbers. For comparison, in 2012, every state except California had increases in pertussis cases over the previous year. In many states, the increase was greater than threefold. As a reminder, the U.S. pertussis vaccine program began in the 1940s with use of whole cell vaccines. These were phased out in the 1990s and replaced with acellular vaccines. In 1992, acellular products were licensed and initially only recommended for the booster doses given at 15 to 18 months and 4 to 6 years. Subsequently, beginning in 1997, acellular vaccines were recommended for the entire childhood series. Tdap vaccines were licensed and recommended for adolescents and adults beginning in 2005. Pertussis vaccination coverage in the U.S. is variable by age group. There have been sustained high coverage with pertussis vaccinations among children. With Tdap in adolescents, there has been substantial increase in coverage following the 2005 recommendation, the most recent survey showing 78% coverage. However, the adult Tdap vaccination program has not been as successful and coverage remains low. The burden of pertussis disease changes with age. This figure shows the average incidence of pertussis by age over a 10-year time period. Infants less than 1 year of age are the group most affected by pertussis. However, there is increased risk of disease among 7 to 10-year-olds and adolescents in comparison with adults. This graph shows reported U.S. pertussis cases by age and year during the last 3 national peaks: 2004 with the blue line, 2010 with purple, and 2012 with green. Children born in 1998 or later would have received all acellular vaccines. The background shading, in the same color as the line, indicates the age range of this cohort during each disease peak. For example, in 2004, in blue, the acellular cohort included children 1 to 6 years of age. Adolescents, however, made up a large proportion of the reported cases at this time. In response to this adolescent disease burden, the Tdap booster was recommended for all adolescents and adults. Following the introduction of Tdap, there was a decline in the number of cases in adolescents, but also an unexpected increase in 7 to 10-year-old children. During the 2010 peak, in purple, these 7 to 10-year-olds were among the first birth cohorts to have received all acellular vaccines. Their high case counts could be explained by waning protection of the acellular childhood series. In 2012, in green, there continued to be an increase in the number of cases among 7 to 10-year-olds. However, cases were now also elevated among 13 to 14-year-olds, an age group again representing the first birth cohorts to have received all acellular vaccines. This was the first time an increase among adolescents had been observed since the introduction of Tdap. In summary, pertussis incidence has been increasing over the last decade. There is a resurgence of disease among older school-aged children despite high vaccination coverage with the primary series, and there is now an increasing incidence of adolescent disease despite recent Tdap vaccination. I'll move on to a description of our study of Tdap vaccine effectiveness in Washington State. Like many states across the country, 2012 was a record year for pertussis in Washington, with close to 5,000 cases reported. This graph shows the epidemiology for the year, with the number of cases noted by the blue bars and incidence by the yellow line. There was an increase in the number of cases among 13 to 14-year-olds, reflecting the national trends I just shared. In Washington, acellular pertussis vaccines fully replaced whole cell vaccines for the childhood series in 1997, and therefore anyone 14 or younger received all acellular vaccines. Adolescents 15 years or older received a mix of whole cell and acellular vaccines. Again, these 13 to 14-year-olds are the first birth cohort to have received all 6 pertussis doses as acellular vaccines. Previous estimates of Tdap vaccine effectiveness range between 66 to 78%. However, all of these studies involved adolescents who received some whole cell vaccines as part of their childhood series. At the time, we didn't know the effectiveness of Tdap among adolescents who had received all acellular vaccines in childhood. The epidemic in Washington provided an opportunity to examine this question, and so the CDC, in collaboration with the Washington State Department of Health, conducted a large-scale vaccine effectiveness study. The objectives of this study were to assess Tdap vaccine effectiveness, or VE, among adolescents in Washington, and to estimate duration of protection among those adolescents who had received all acellular vaccines. Confirmed, probable, and suspect pertussis cases were included in the study. CSTE case definitions were used for confirmed and probable cases. Suspect cases were those with a positive PCR test and less than 2 weeks of cough for unknown duration of cough. We conducted a matched case control study. Our study population was 11 to 19-year-old residents of Washington, born between 1993 through 2000. We focused on the 7 counties with the highest case counts. All reported cases with cough onset from January 1st through June 30th, 2012 were included. We selected 3 controls for each case, matched on birth year and provider. Potential controls were excluded while in the field if provider records noted suspicion of pertussis, the patient had been discharged from the clinic, or the last clinic visit was prior to 2005. Vaccination history was initially verified through chart abstraction at provider offices, and then, if necessary, was supplemented by the state immunization registry, followed by parent phone interviews. For a participant to be considered vaccinated, a Tdap vaccination date was confirmed in the provider records or supplemented by the registry or parent interview. A participant was considered unvaccinated if no record of vaccination was found in provider records or the registry, and Tdap non-receipt was confirmed by a parent. Additionally, a participant was considered unvaccinated if Tdap receipt was confirmed, but the vaccination occurred within 2 weeks of enrollment or after enrollment. Finally, a participant's vaccination status was considered unknown if Tdap vaccination was not documented in the provider records or the registry and parent interview was inconclusive. Before I discuss the results, I'd like to add the caveat that these results are preliminary pending a final validation process. However, we don't expect substantial changes. This map shows all adolescent cases in Washington during our study timeframe. The 7 counties that participated are in yellow. Our study included 85% of all Washington adolescent cases and 74% of all Washington providers reporting adolescent cases. Data was collected for 94% of all adolescent cases reported during the study timeframe. 168 participants were excluded from the study population for reasons including being a prior pertussis case, having an out-of-state home zip code, receiving a misadministration of DTaP instead of Tdap, receiving a Tdap prior to 10 years of age, or receiving 2 or more Tdaps. 861 cases and 2,485 controls were included in the study population. Of the 861 cases, 78% were confirmed. With regard to the demographics of our population, there was no significant difference in sex between cases and controls. However, 55 to 65% of ethnicity and race data was missing in the provider records and therefore is non-informative. Tdap vaccination status was verified in 94% of the study population. 83% were vaccinated and 11% were unvaccinated. Provider records contributed vaccine history for 76% of these participants, and the registry supplemented an additional 16%. Parent interviews only supplied Tdap vaccine history for 8%. We were unable to verify vaccination status in 6% of the study participants. These participants were excluded from the analysis. This left 826 cases and 2,306 controls in the analytic population. Among the 2,761 participants who received Tdap, 73% were vaccinated at age 11, indicating adherence to current Tdap recommendations for vaccine receipt at 11 to 12 years of age. This graph shows the number of participants by age in the analytic population. The median age was 14 years, consistent with the elevated disease incidence in this age group. I'll now focus the analysis specifically on the age groups that would have received all acellular pertussis vaccines. This included participants 11 to 14 years of age, born from 1998 through 2000, a total of 1,682 participants. Of those in the acellular population who were vaccinated, nearly all received Tdap less than 3 years prior to study enrollment. The overall VE for this acellular population was 65%, with 95% confidence intervals of 50 to 75%. This result was consistent with the previous studies that I shared with you. When we examined duration of protection, the initial effectiveness within 1 year of Tdap vaccination was 75%. Following this, the VE declined substantially. By 2 to 4 years post-vaccination, the VE was less than 40%. We performed supplemental analyses to assess the stability of our estimates. The pink line in this graph illustrates the duration of protection data shared in the previous slide. The yellow line shows duration of protection estimates when the acellular population is restricted to those with documentation of a complete childhood series. We further restricted the analysis to those with a complete childhood series and confirmed case data, shown by the blue line. In all scenarios, the results were comparable. We know one question that remains unanswered is whether receipt of whole cell vaccine could influence the effectiveness of subsequent acellular booster doses. Although our chief objective was to estimate VE for adolescents who received all acellular vaccinations, which is the population currently at risk, we were very interested in examining this issue. However, there were limitations to our data which restricted our ability to perform this analysis, which I'll discuss now. The population who would have received a mix of whole cell and acellular vaccines included adolescents 15 to 19 years of age, born from 1993 through 1996. In our study, this was a total of 852 participants, a fairly small number. Secondly, among this mixed population, there was a greater proportion of participants with unknown Tdap vaccination status, noted by the yellow bars. We were unable to verify vaccination status in this population for several reasons. Older study participants were less likely to have vaccinations documented in provider records or the registry, and they were less likely to have visited a provider recently. This increasing trend of unknowns by age could lead to misclassification bias. Finally, of those in the mixed population who were vaccinated, most received Tdap 4 to 5 years prior to study enrollment, a much different time frame than those of the acellular population who were mostly vaccinated at less than 3 years prior to enrollment. For these reasons, we were not able to reliably quantify VE by year since Tdap vaccination. However, we were able to calculate an overall VE estimate for this population. The overall VE for the mixed population was 41%. Again, this population was heavily weighted towards participants who received Tdap at least 4 years prior to enrollment, resulting in a lower VE. These findings suggest that there is Tdap waning among participants who received some whole cell vaccines. However, the degree of waning could not be quantified. Additionally, no direct comparison of Tdap VE or duration of protection could be made between the acellular and mixed populations, given the difference in time since Tdap vaccination. In summary, among adolescents who received all acellular vaccines, Tdap demonstrates modest effectiveness but has substantial waning over time. This waning is consistent with the observed epidemiology. These data on vaccine effectiveness helped inform the decision analysis for Tdap revaccination, which will be presented shortly. I'd like to acknowledge the many individuals who contributed to this study. Thank you.
Thank you much. I think at this point we're open for a few questions, if there are anything. Dr. Harrison.
Do you know the frequency of protactin mutants in your population and whether there was any difference by any effect on vaccine effectiveness?
That is not something that we looked at in this study.
Other questions, comments? I think we're dealing with the after-lunch phenomenon here. Or the presentation was very good, and probably the latter. I'd like to move on then with the Dr. Liang and discussion on Tdap revaccination safety and immunogenicity.
Thank you. For over a year, the working group has reviewed the following as they discuss considerations for Tdap revaccination of the general population. At the February ACIP meeting, Dr. Tom Clark presented a summary of these data with the work group's conclusions and began the dialogue on Tdap revaccination. And as Dr. Sawyer pointed out, at the February session, the committee guided the work group to consider a second dose of Tdap instead of multiple doses. Dr. Acosta has presented the epidemiology of pertussis in the U.S. and results from a Tdap vaccine evaluation. I will present a brief summary of safety data after receipt of a second dose of Tdap and data on the immune response to vaccine, including antibody persistence after the first Tdap and immune response to a second dose. These were previously presented to the committee in February. Before presenting a summary of these data, the following slides are the sum total of published studies reviewed by the work group. Studies from several countries have measured antibody levels after receipt of one dose of Tdap, either Adacel or Boostrix. The antibody levels of diphtheria, tetanus, and pertussis were measured at several intervals through 10 years after vaccination. Also reviewed by the work group were studies from other countries that looked at the safety and immunogenicity of a second dose of Adacel or Boostrix at a 5 or 10-year interval after first Tdap. And just to remind the committee, both pharmaceutical companies are conducting clinical trials of a second Tdap 10 years after the first dose. Sanofi Pasteur's study for Adacel is complete and was presented to the work group and summarized to the committee in February. And GSK began a clinical trial for Boostrix in the first quarter of 2013 and anticipate a report in 2014. Safety data after receipt of a second Tdap at 5 and 10-year intervals were reviewed by the work group. The sum total of the most commonly reported adverse events after receipt of a second dose at a 5 or 10-year interval are listed here. At the site of injection, the most commonly reported adverse events were pain, erythema, and swelling. For systemic adverse events, the most commonly reported were myalgia, headache, and malaise. Reporting rates were comparable at the 5 and 10-year interval, as well as generally comparable after receipt of a first Tdap. For both local and systemic adverse events, the majority were mild to moderate and self-limited. Of the few serious adverse events reported, none were related to the receipt of a second Tdap. The following slides are a representative summary of Tdap antibody persistence over time and response to a second dose. These are geometric mean concentration curves for diphtheria and tetanus antitoxin antibodies before and after receipt of Tdap in two populations or receipt of TD, and followed through 10 years. The Tdap product was Adacel. Seroprotection for tetanus and diphtheria are defined as greater than 0.1 IU per ml, which is represented by the orange lines. For diphtheria and tetanus, you see generally comparable curves for Tdap and TD. There is a boost at 1 month with gradual decline above baseline at 5 years to near baseline at 10 years. By 10 years, the great majority were above seroprotective levels. For Boostrix, the GMC curves through 10 years are similar to the previous slide, and out to 10 years, the great majority were above seroprotective levels, as represented by the orange line, at 0.1 IU per ml. Also included is the robust response to a second Tdap at a 10-year interval, which is similar to the response after the first dose. Although not shown, response to a second dose of Adacel 10 years after first Tdap is comparable to the first dose. Here are the GMC concentrations of pre- and post-vaccination for the first and second Tdap after a 5-year interval. The measured response is robust and similar to after a 10-year interval. Note the differences between the two diphtheria graphs. For the group on the right, pre-first Tdap baseline was higher. Authors from the study note that this group was younger and had likely received a childhood diphtheria toxoid-containing vaccine more recently. Also, the pre-second Tdap baseline was also higher. Before receipt of the second Tdap, this group received a quadrivalent meningococcal vaccine, which is conjugated to diphtheria toxoid. In summary, the robust antibody response and persistence of diphtheria and tetanus antibodies are comparable to receipt of TD. And although antibodies wane, levels are protective out to 10 years. And after receipt of a second Tdap, immune response to tetanus and diphtheria were robust at 5 and 10-year intervals. For acellular pertussis vaccine antigens, after a single dose of Adacel, Pertussis antibody levels peak after 1 month and then rapidly decline within the first year, with slower decline through 10 years. Similar curves are seen with adolescents who receive Atiso. A reminder to the committee that for pertussis, there are no defined antibody levels which correlate to protection. After a single dose of Boostrix, similar curves are observed through 10 years. Response to a second Boostrix after a 10-year interval is also shown. And as you can see, the response to the second dose was similar to the response after the first. And although not shown, a second dose of Atiso at a 10-year interval also showed similar response after a first dose. For Atiso after a 5-year interval, response to a second Tdap was robust, but was lower compared to the response after the first dose. But note that at 5 years, baseline for pertussis antibodies before a second Tdap were higher. For pertussis antibodies, there is a rapid decline during the first year with a gradual decline afterwards. After 10 years, the concentration of pertussis antibodies remained higher than pre-vaccination levels. We know that antibody contributes to protection, but there are no defined antibody levels which correlate to protection for pertussis. And for a second Tdap, the immune response is similar to the first dose in cohorts boosted after 5 or 10 years, and is similar in naive groups who received a first Tdap. From the data presented thus far, the work group concluded that a second dose of Tdap is safe and immunogenic at a 5 or 10-year interval. However, as you saw earlier, Tdap vaccine effectiveness is 75% within the first year, but substantially wanes in 2 to 4 years. These vaccine attributes will inform the decision and cost-effectiveness analysis that will be presented next by Dr. Hajime Kamiya.
Good afternoon. Because we have not described this process in quite some time, I'm here to review the procedures for the ACIP committee members and for the meeting attendees on how we go about reviewing presentations of economic studies to ACIP. ACIP asked CDC economists to develop a process by which these studies could be reviewed. And in 2005 and 2006, an ad hoc committee of 2 CDC economists and 1 ACIP member did just that. The procedure was formally adopted by ACIP in 2007, and since that time, over 20 studies have been reviewed. In the mid-2000s, economic studies of vaccines and vaccination were becoming more common and more commonly presented to ACIP. The ACIP charter calls for inclusion of economic evaluations in the deliberations of the committee, and prominent journals had already provided guidance related to economic studies. The procedure that we go through applies to studies presented to the full committee, such as today, its subcommittees, and its work groups. Researchers wishing to present results of economic evaluations to ACIP are required to submit 2 sets of materials. One is a manuscript describing the methods and results of their study, with more emphasis on methods and results, less emphasis on introduction and discussion. They must also submit the slides that they wish to present to use in their presentation. And this whole process includes studies that are conducted by CDC economists as well as non-CDC economics researchers. The materials must be submitted to the relevant ACIP work group chair and to the CDC work group designated federal officer at least 8 weeks before the meeting at which the researchers desire to present the study. and exceptions may be allowed for that 8-week rule in extraordinary circumstances. Oops, sorry. The studies undergo anonymous peer review, and that's managed by the lead economist of NCIRD. The reviewer may consult with CDC subject matter experts to complete the review no less than 4 weeks before the meeting. And the review results are then returned back to the researchers with time for response and revision. For those interested, at the ACIP website, there is a link to a document that describes the procedures in detail.
Good afternoon. Today, I'll present the results from the decision and cost-effective analysis for a second Tdap for adolescents and adults. This framework for this analysis was presented to ACIP in February. This analysis was done with CDC health economist Dr. Bo-Hyun Cho. Here's an overview of my presentation. We performed this decision and cost-effective analysis for the following reasons. The incidence of pertussis among adolescents and adults is increasing. The ACIP Tdap recommendation is approaching 10 years since first being recommended, and available data shows that Tdap duration of protection seems short. The objective is to evaluate the cost-effectiveness of different scenarios of revaccination of Tdap for healthy adolescents and adults in preventing pertussis in this population. This model will compare a Tdap revaccination strategy to no revaccination. No revaccination is defined as receiving 1 dose of Tdap at age 11, which is the current adolescent recommendation. The cohort population is healthy 11 years old, who will be followed over time for 20 years. Outcomes include number of cases, outpatient illnesses, hospitalization, and death. We examined direct and indirect costs from the societal perspective and calculated quality-adjusted life years, or QALY. This figure shows the average incidence of pertussis by age from 2002 to 2011. Note the higher incidence among adolescents compared to adults. Our model uses weighted sum of reported pertussis incidence among vaccinated and non-vaccinated with a weight of Tdap coverage rate. Thus, the epidemiology of pertussis among different ages is an important consideration. Across all age groups in this analysis, the majority of cases, or above 97%, are outpatient. Pertussis-related hospitalization and death are rare. Our model focuses on persons aged 11 to 30 years. The incidence for this age group in NNDSS is approximately 7 cases per 100,000 population. However, since NNDSS is a passive surveillance, it is important to take into account the underreporting of pertussis cases. Several published studies have calculated the incidence of pertussis. Although the age range, inclusion criteria, and diagnostics testing varied across these studies, the calculated incidence ranged from 66 to 507 cases per 100,000 person years, which is much higher than the incidence from NNDSS. Another important consideration was to model realistic and feasible scenarios and utilize the current immunization platform and practices for adolescents and adults. Based on this background consideration, we chose 2 scenarios to evaluate the cost effectiveness of second dose of Tdap for healthy adolescents and adults. This is current recommendation schedule for Tdap and TD for adolescents. Our first scenario is to add an additional Tdap dose for adolescent at age 16. This is based on the current epidemiology of pertussis and also utilize the current adolescent immunization platform where a second dose of MCV4 is recommended. Our second scenario is to replace the first decennial dose of TD with Tdap at age 21. This is a first half of decision analysis model with the 11-year-old cohort either receiving or not receiving the first Tdap. Only those who received the first Tdap are included in the revaccination group. In this analysis, persons who did not receive the first Tdap at age 11 were not eligible for revaccination, but were followed until age 30. They were also not given a catch-up first dose when others received their second dose. Individuals from each group experienced either pertussis or no pertussis. The outcome of outpatient illness, hospitalization, and death were assessed in those who experienced pertussis. Those who recovered from the illness or did not have pertussis were then evaluated for receiving a second Tdap. Depending on the scenario, either receiving a second Tdap at age 16 or 21, the revaccination eligible group was sorted based on the vaccine coverage rate for a second dose. As with the first dose, individuals from each group experienced either pertussis or no pertussis, and the same outcomes were assessed. This decision tree was repeated as we followed the cohort population over time. The general parameters of the model incorporated disease incidence, population, disease outcomes, and discount rate. For the baseline estimate, disease incidence was based on the 10-year average incidence from 2002 to 2011. Population size was based on the 2010 U.S. Census and incorporated current age-specific natural death rate obtained from the 2008 life table from the National Vital Statistics System. The outcome probabilities were based on the mean percentage of cases, with these outcomes also based on NNDSS data. The discount rate in the base case was 3%. Discount rate is applied to express future outcomes in terms of present value. Parameters of the model related to vaccine include vaccine effectiveness, waning of vaccine effectiveness, and vaccine coverage rate. Vaccine effectiveness and waning were based on the data from Washington State investigation as presented by Dr. Acosta. Waning of vaccine effectiveness was decreased by 15 percentage points each year post-vaccination. Vaccine coverage rate for the first Tdap was 78%. This is a 2011 Tdap coverage rate in adolescents 13 to 17 years old age from NIST. For the second dose at 16, coverage was 50%. This number was based on our assumptions. For a second dose at 21, coverage at 64% was based on current TD coverage in 19 to 49 years old. Cost parameter for this model is disease and vaccine costs. The average number of visits to the health care provider prior to the diagnosis of pertussis and duration of cough was calculated from enhanced pertussis surveillance data. Lengths of hospitalization and disease costs were based on market scan database using a cost-benefit analysis of pertussis vaccination in adolescents and adults. Outpatient costs include treatment costs and prescription drug costs, such as antibiotics and cough suppressants. Hospitalization costs include both hospitalization costs and any associated outpatient services. Productivity loss, or indirect cost, is a productivity loss because of death and calculated based on economic productivity by age, so its value varied with the age of the cohort. Program costs include vaccination. We use the cost of $50.14 for the first Tdap and the second Tdap given at 16. For the second given at age 21, a vaccine cost of $15.31 was used. This is a cost increase of Tdap relative to TD. Our median wage for this analysis was $16.57. To calculate quality-adjusted life years, we need to apply appropriate health utility indices, or HUI. HUI measures a person's preference for specific outcomes on a scale of 0 to 1, on which 0 typically represents a state equivalent to death, while 1 represents the best imaginable health. From the study by Grace Lee, a mean HUI for mild coughing and severe coughing was calculated. In our model, we applied the mild cough HUI from Grace Lee's paper as outpatient HUI and severe cough HUI as hospitalization HUI. There are several assumptions for this analysis. Although considered, we did not include acquired immunity after infection or vaccine herd immunity because there are varying data on how long acquired immunity lasts, and there are no data on the effect of Tdap vaccination on herd immunity. Also, adverse events following Tdap immunization were not included due to the low incidence of severe adverse event following immunization. We did not include persons who got pertussis but died from a different cause, since the number of pertussis-related deaths in this age group is rare. As several clinical trials have shown, the immune response from the second Tdap is similar to the first dose. A higher response or booster effect is not seen. And finally, although the hospitalization rate among vaccinated and unvaccinated persons will likely be different, the number of hospitalized cases is so small in our study population that we assume these two groups have the same population rate, hospitalization rate. So now on to the results. This line graph shows the projected number of pertussis cases calculated by our model for the current recommendation and 2 Tdap revaccination groups in the cohort of 11 years old over 20 years period. The pink line is the number of cases following the current recommendation. The yellow line shows the projected number of pertussis cases calculated by our model for the revaccination at age 16. It falls behind the pink line until before receiving second Tdap. The area between the pink and yellow lines indicates the decreased number of cases due to the second Tdap. Likewise, the light blue line shows projected case for revaccination at age 21. The light blue line falls behind the pink line until being revaccinated, and area between two lines indicate the decreased cases by revaccination. The number of cases calculated by the model are shown in the table. If we follow the 11-year-old cohort for 20 years, revaccination at age 16 prevents 284 more cases compared to the current recommendation, and 168 more cases are prevented by revaccination at age 21. The majority of cases are outpatient illnesses. This table summarizes the cost associated with Tdap revaccination. Because revaccination at age 16 is adding a new dose to the current program, the program cost is higher compared to the scenario giving a second dose at age 21. Total cost, or the sum of vaccine program costs, direct cost, and indirect cost, is the highest when revaccinated at age 16. The total cost is approximately $260 million, and the difference between the cost for current recommendation is approximately $77 million. For age 21 revaccination scenario, the total cost is about $205 million, which is about $23.5 million more than the current recommendation. Before presenting the result of the cost-effective analysis, I would like to remind the committee the number of cases prevented for different outcomes in two scenarios compared to the current recommendation. Tdap at age 16 will prevent 284 cases compared to the current recommendation. This is about 5% of cases prevented by the current recommendation. 98.6% of the prevented cases are outpatient illnesses, and very few severe cases that would require hospitalization or result in a death are prevented. This trend is similar for the second Tdap at 21. Additional 3% of cases are prevented compared to the current recommendation, and again, the majority of the cases were mild cases. Based on these numbers, we calculated dollar per cases prevented and dollar per QALY saved for each revaccination scenario compared to the current recommendation. Net costs are different of total costs between current recommendation and each scenario. Dollar per case saved for 16 years old revaccination was about $270,000, and for revaccination at 21, it was approximately $140,000. And for dollar per QALY saved, it was $16.7 million and $14.7 million for each scenario, respectively. We also conducted one-way sensitive analysis for several variables with a variety of ranges. I will be presenting the result from the conditions listed here. For vaccine coverage rate, because uptake of a second dose at age 16 is unknown, we assume the age range from 25 to 100% coverage. We also use 40 to 90% coverage for 21 years old revaccination. For waning of vaccine effectiveness, we assumed a 10 to 25% range. For underreporting, we applied 100 times underreporting based on the comparison between NNDSS data and the literature review. However, we think that severe cases are well captured by NNDSS compared to the mild cases. Thus, we compared NNDSS and the nationwide inpatient sample data for pertussis-related hospitalization and death cases. From this comparison, we applied 2 times underreporting for severe cases calculation. Now I'll summarize the number of cases prevented in one-way sensitivity analysis. For each parameter listed, the number of cases prevented by each scenario compared to the current recommendation under the same condition are presented. And just as a reminder, under the baseline condition, revaccinating Tdap at age 16 prevents additional 284 cases, and 168 additional cases are prevented with a second Tdap at age 21. The number of prevented cases changed subtly under different vaccine coverage rate and waning of vaccine effectiveness scenarios. However, if we take into consideration underreporting, the number of prevented cases changed greatly. Because underreporting of cases has a strong impact on our analysis, in the next slide, I will present the summary of one-way sensitivity cost-effective analysis with the underreporting factor being applied. Results of calculated dollar per cases prevented and dollar per QALY saved applying under reporting factor are shown in this table. Even though the number of cases prevented are large, the dollar per QALY saved still remains high. Finally, we performed several multivariate sensitive analysis. I will present the results from the most favorable condition, which are high coverage rate for second Tdap dose, less waning of vaccine effectiveness, and applying underreporting factor. For the multivariate sensitive analysis under favorable condition, the number of cases prevented became larger comparing to the current recommendation scenario under the same condition. But due to the higher vaccine coverage rate for the second Tdap, the net cost remains high. Thus, the dollar per QALY saved is still $200,000 for revaccination at age 16 and $240,000 for age 21 revaccination. Results from this model raise the question about the need for the first Tdap at age 11. Using the same model under baseline condition, the number of pertussis cases under no first Tdap is shown in the white line. Without first Tdap at age 11, the number of cases are more than 2 times the number of cases when Tdap is given at age 11, and declines as the cohort gets older. By age 20, the number of cases becomes similar to the rest of the scenarios. The main conclusion that can be drawn from this analysis are: a second Tdap results in a modest decrease in the number of cases. The majority of the cases are outpatient illnesses. A second dose at age 16 will prevent more cases than the current Tdap program, or a second dose at age 21. However, adding an extra dose to the immunization program will result in higher program costs. A second dose at age 21 is in less cost, but less disease is prevented. Both revaccination scenarios had high dollar per quality saved. Based on one-way sensitive analysis, incidence is the main driver of the cost effectiveness in this model. As incidence increases, the cost effectiveness of second Tdap increases. Even under the most favorable condition for multivariate sensitive analysis, we still see high dollar per quality saved. And finally, the current Tdap program does have an impact on preventing pertussis cases. I would like to acknowledge the following people from CDC for their help with this analysis. Now, Dr. Liang will summarize the work group conclusion on recommendation for the second Tdap.
After review of the data on Tdap revaccination, the work group is not in favor of recommending a second Tdap. I will now present the following work group considerations and rationale for not recommending a second Tdap for the general population. The work group recognizes the increasing burden of pertussis in the United States and the need for an effective strategy to reduce this burden. But the epidemiology shows that the burden of pertussis disease changes with age. The highest morbidity and mortality of pertussis is in infants. We have a strategy in place to vaccinate pregnant women during each pregnancy to decrease pertussis morbidity and mortality in this age group. Later this session, the committee will be hearing encouraging data from Australia and the UK which support this strategy. For adolescents and adults, the majority of cases are outpatient illness, and pertussis-related hospitalizations and deaths are rare. As a reminder, Tdap is FDA approved for single use only, and so a recommendation for additional doses would be at this time considered off-label. Yet clinical trials support that a second Tdap would be safe and immunogenic at a 5 or 10-year interval, yet the working group recognizes the limitations of this vaccine. The initial immune response to a second Tdap is similar, but not greater than the response to the first Tdap. Diphtheria and tetanus protection would persist for 5 to 10 years post-Tdap, but pertussis antibodies decline rapidly after the first year, suggesting that protection wanes, which would likely limit the impact of a second Tdap on disease burden. As the Washington Tdap evaluation shows, Tdap protects against pertussis, but this protection wanes in a few years after receipt of Tdap. Waning after a second Tdap would likely be the same. And as Dr. Kamiya just presented, the decision and cost-effectiveness model suggests that with a second Tdap, the reduction of disease burden would be limited. A reminder that this model followed persons from 11 through 30 years of age. In this age group, the model showed that the majority of cases are outpatient illness, and hospitalizations are few and deaths are rare. Although cost-effectiveness improves if we assume underreporting, the proportion of cases prevented is small. Under the baseline conditions, by adding a second Tdap at either 16 or 21, the preventable burden compared to the current recommendation ranges from 3 to 5%. And if we consider the most favorable conditions in the model, the preventable burden does not greatly improve and ranges from 4 to 10%. The work group concluded that the data do not support a general recommendation for a second Tdap, and therefore does not favor a universal recommendation. The work group supports letting stand the current recommendation for a single dose of Tdap in adolescents and adults. The work group also strongly supports focusing efforts on preventing pertussis in infants through the existing ACIP recommendation to vaccinate pregnant women during each pregnancy. Though a universal recommendation for a second Tdap is not favored, the work group is willing to consider revaccination of at-risk populations, but anticipates similar limited impact on overall disease burden. In closing, the work group asked the committee for feedback to not recommend universal second Tdap. Also, should the work group consider additional Tdap for at-risk populations, and if so, who should be included?
Thank you very much, and I think we can open to questions. Dr. Dushan.
Thank you. Thank you for that series of really clear presentations. I agree with your conclusion, but I have two questions that might make me, might influence how much I agree with your conclusions. The first is about, on the immunogenicity data that Jennifer Liang presented, your slide that showed pertussis toxin, FHA, and PRN, Fimbriae antibody levels seem to suggest that the response to pertussis toxin was much lower than to the other antigens, and my understanding is that might be perhaps the most important toxin. So your conclusion was that the antibody response is similar for the first and second doses, but with such a diminished response to pertussis toxin. I was wondering if I was off base in thinking that that really isn't equivalent because the pertussis toxin is so much diminished.
Agreed. I mean, the statement was in terms of the overall group of pertussis antibodies, but you are correct in terms that the response to PT was lower for both the 5-year, at a 5-year interval and at a 10-year interval. As to the protection of what PT provides or the importance of PT, I would actually look to the experts out in the audience to answer that.
But it leads me to wonder whether the booster would be even less effective than the primary, which, as we know, is only modest.
Yeah, I think it certainly wouldn't be higher, and I think there's some suggestion or belief that PT is probably a critical antibody in protection, and generally concerned that because you don't respond to very high levels, you drop to pretty low levels pretty quickly. So.
Can I ask a second question?
Absolutely.
Thank you. On a different topic now, the you know, as with this modestly effective vaccine and the resurgence of pertussis we're seeing in fully immunized younger children, more older people will be exposed to pertussis, naturally occurring wild-type pertussis. And so I'm also wondering about the implications of that on the modeling when we have more people, you know, after these large outbreaks having pre-existing natural-type immunity. Was that accounted for at all in the model, or would we expect that the vaccine would be even less beneficial than was modeled in the face of these large naturally occurring outbreaks?
Dr. Duchin, could you just clarify that question?
Yeah, so if, you know, we're having these large outbreaks now intermittently in immunized children. And so during these outbreaks, there's increased levels of community transmission in older people getting wild-type infection, both adolescents and adults. And so I'm wondering if that wild-type, you know, that wild-type, the occurrence of wild-type infection and the consequent immunity that provides was considered in the model, that a lot of people will already be exposed to wild-type infection and therefore not get any additional benefit from a booster dose.
I think, so looking at the model specifically, we did just limit it to looking at the 11-year-old dose, and so the epidemiology that followed was from 11 through 20, you know, through 30 years of age. So we didn't there wasn't any, the incidence data did include some of the influences from that, but the model specifically was targeting, looking at the younger age group receiving it. I think in terms of the impact on older adults, we don't have there are very few data, at least that I'm aware of, in terms of the impact of what Tdap would be in that older population. I don't know if Tom, if you'd like to comment.
I mean, we did have some debate about this, and you know, if you look at seroprevalence studies, you can find like 6% of people seroconvert over the course of a year. But we decided that even 6% seroconversion is kind of much lower than vaccinating whatever 90% of people, and so we did choose to exclude it from the model because it makes it easier. And once you start talking about a transmission model, funny things happen. But I don't think we know about the experience of people now getting disease and their boosting response, and to what degree they're protected by natural infection at all.
I have Dr. Plotkin, Dr. Warshawski, and then Dr. Bennett. Microphone.
Now? Yes. So we've heard some very interesting data, but essentially the conclusion has been a pessimistic one. In effect, the conclusion is that we can do nothing about adolescent and adult pertussis. That doesn't take into account the impact on confidence in vaccination. So for many of us, the issue is how can one improve on the current pertussis vaccine? And there are, and I'm not going to go into a long discourse on that, but there are a number of possibilities. What I haven't heard, and perhaps these studies are in course, what I haven't heard are attempts to better define the correlates of protection against pertussis. And that is essential because it is going to be probably impossible to do a controlled efficacy study on a future vaccine for ethical and practical reasons. And therefore, licensure is going to depend on establishment of correlates of protection. As was the case, incidentally, in licensing the current Tdap based on the antibody results from the 1990s European trials. So I would certainly hope that such studies are in course to define those correlates, prospective studies, including such things as estimation of cellular immune response, cytokines, et cetera. In addition, there is an issue that has come up based on baboon studies, and that is the possibility that is shown in the baboon model that the acellular vaccines do not prevent pharyngeal, nasopharyngeal infection, and that therefore the circulation of the organism continues unabated. Now, that could be relatively easily established in the current epidemic situations, and I think it will be extremely important to do that. So, yes, I agree that the current vaccine is not going to do the job, but it is essential that we establish how to improve those vaccines.
Thank you. Dr. Warshawski.
Thank you. Brianna Warshawski from the National Advisory Committee on Immunization. I know this won't change the model much, but I just wondered, for the vaccination at 16 versus the cost of vaccinating at 21, they're substantially different because one's adding on to the TD, right? Did you consider the fact that if you vaccinate at 16, you're actually going to defer your next TD to 26 instead of 21, and that eventually might be some savings there because you'll have less TD in the end?
No, we didn't.
And can I just ask another question? The fact that you don't consider the transmission, that there may be some decreased transmission, what was the rationale again for that? Just because there's no evidence that actually happens, or?
Yeah, so we looked for the data, but we couldn't find it. the good ones to apply.
Okay, Dr. Bennett.
Thank you. A couple of questions. One is just, I'm sure the committee discussed not really including as directly the impact on adolescent and adult populations because of the lack of data. But I wondered if someone could comment on that a little bit, and because it could really go either way. It could be that the naturally occurring disease would make more people immune and decrease the efficacy of the, but it also could be that because we so underestimate adolescent and adult disease, that actually it would have an impact of improving the cost benefit. But the second question I had was about considering other costs. So it looks like in your model, the only productivity costs that were considered were those due to premature death, and I wondered if you considered any other costs, such as public health costs, parental costs, employee costs, and so forth.
So for the additional costs, we didn't really include, but the loss of by death, that's the only thing that we considered. And I don't know if you could add it.
So was there any discussion on the committee about including other parameters, if you're looking at it from the perspective of societal? The public health costs of this are enormous, and I think might be something we'd want to include in a model.
And along that line, the costs included in the home quarantine of a child or an adult, the loss of work for that adult if they have to stay home for the obligatory 5 days are worthwhile considerations. Dr. Turner.
Jim Turner, American College Health, and a couple of the points were just brought up, but I think your cost per quality is the absolute worst case scenario. And when you consider, if it's possible to consider in factors such as transmission to others and the impact that the disease has on others and other families, the economic impact on families, and having been involved with these outbreaks in my community, it's a pretty overwhelming burden on society. And I'm having a hard time reconciling the fact that at the very beginning of these presentations, you talked about 50,000 cases in 2012, scattered predominantly among adolescents, yet your cost-effective analysis says you're going to save 284 cases, yet each cohort in 2012 had between 2,000 and 3,000 cases. We know for a fact would not have given those adolescents a second dose prevented it. So it just seems to me you're looking with fairly primitive data at this cost-effective analysis, and I suspect if it were possible to gather all this other data, the cost would come down substantially.
I mean, we agree. I mean, the working group did struggle with trying to include or wanting to incorporate indirect protection and that such, but there are no data to suggest at this time what the actual prevention would be from indirect protection with vaccination. I don't know if there's any other.
Okay, I have Dr. Go ahead, Tom.
Yeah, it was just to echo Jen. I mean, there's no data for indirect protection, and there's some data for absence of indirect protection. In our surveillance data, we saw no impact of adolescent coverage on infant or younger disease. Similarly, over time, there's just more and more disease, and no suggestion yet that that's protecting cohorts of kids.
I guess, Tom.
And then if you increase the incidence by 100-fold, the cost effectiveness is still sort of inching towards favorable, but not there yet.
So I guess we're willing to put up with 50 to 100,000 cases of pertussis a year for like ever and ever? Or
no, I think the the conclusion from the model is the limited impact in reducing that burden by another dose.
I'm going to have Dr. Sawyer follow up very quickly, and then just for keeping in order, Dr. Jaffe, Dr. Salisbury, Phil Hausbeck, and then Dr. Sawyer again, unless this is it.
Yeah, this is just a short follow-up to Dr. Turner's comment. I mean, not everything was worst case. I mean, among the assumptions was 100% vaccine coverage, which is a long way from where we are, and only 10% waning per year in antibody effectiveness, which is much less than we seem to be seeing.
Dr. Jaffe.
Harold Jaffe from CDC. I know this was beyond the scope of what the working group was considering, but given the short duration of protection from the vaccine, is there still really a rationale for the use of the first dose of Tdap in adults other than pregnant women?
Well, so we did include so there's a much greater impact of dropping the 11-year-old dose than one might expect based on the benefits of an additional dose. The coverage with the adult dose is not there yet, so the program itself is sort of minimal. But yeah, we didn't re-look at the adult recommendation.
Is that something worth considering?
Yeah, I mean, I think that as you'll hear going forward, the highest priority for the program right now is the pregnancy vaccination, a subset of the adult doses that are not yet where we'd like them to be. And I think that that is really where the focus is. The issue of what effect raising adult coverage would have on morbidity is harder to say because the surveillance is not as complete for that population.
Dr. Salisbury.
Yes, thank you. Just building on, I think, what Anne was getting at, I was wondering, had you considered that either of these strategies might just push the age of infection to the right and then cause more infant infections because it's the wrong population that will then be getting pertussis?
Yeah, so we did consider like vaccinating at age 13 where they have more higher incidence than 16, but like you said, we thought that it was going to just push to the right. And also we wanted, like I said, we want to be the scenario to be realistic, so given the platform at 16, we utilized that to see how the numbers going to be. So if we vaccinate, we might see the graph shift to the right.
But that's exactly my worry, that if you shift the cases to the right, you may cause more infections in infants.
Dr. Clark?
Yeah, I think we see two phenomena. One is that protection wanes, and so you may reduce the burden temporarily, but it will continue to increase. But the phenomenon seems to be what happens early. So kids who get acellular vaccination seem less protected, and so they're already at higher risk. So the strategy, as you well know, to prevent disease in that most vulnerable group is the pregnancy vaccination. That's the best. That's I think the only scenario that's going to reduce the risk in the youngest groups.
Mr. Hausbeck.
This is Phil Hausbach from Sanofi Pasteur, and of course, we're the manufacturer of Adacel, so I want to make sure that that's clear. But I have a couple of points and then a question for the group. The first point is 65% benefit over 2 to 4 years with a bacterial vaccine is real value to the individual for protection, so we need to keep that certainly in mind. The other is early for Dr. Dushin. I think in terms of looking at PT responses, also you have to take into account if laboratories changed, et cetera. So the working group should ask the questions of those people doing those tests to make sure it's apples to apples. And then my question is for the modelers. Did you include the cost of PCR testing, and if that would go down over that, in that adolescent cohort, if over 2 to 4 years you were able to reduce that by 65%, does that also add to a cost benefit for this immunization? And I do know that PCR tests are about $100 a pop, so I'm sure we're doing a lot of it out there, and it'll be interesting to know how much that's increased over the years.
No, we didn't include that.
Dr. Herman?
With regards to some of the comments about public health and all the issues around the cases that we'll continue to see until we have better vaccines, I would say some public health approaches to pertussis might change. For example, perhaps, as in California already, we don't necessarily recommend post-exposure prophylaxis for all contacts. We try to prioritize it to high-risk contacts, et cetera. We tell local health departments they don't need to call everybody back in 2 weeks to see if they're still coughing. Those sorts of things that really can at least save a little bit on public health. And I would, even with the issue of the PCR, there may be more clinicians who, will treat and diagnose clinically in the setting of a lot of cases, and perhaps PCR testing isn't always necessary other than to confirm a case for public health, or for, what other reasons might be necessary. So I think there's a lot of things that need discussing here in this era of increasing pertussis.
Dr. Curran.
I just wanted to build a little bit on what Dr. Jaffe and Dr. Salisbury said about the issue of the routine adult dose of Tdap. And I'm really wondering whether it might be worthwhile for the working group to go back and look at that standing recommendation. We don't do a particularly good job at getting this dose to all adults. We could perhaps be focusing our efforts better, certainly on pregnant women, perhaps on cocooning strategies, we're about to hear about those, perhaps on healthcare workers, but targeting those particular groups rather than universal immunization.
Yeah, Kevin, a couple of comments as well. I think one is we know so very little about how much pertussis is out there through just regular population surveillance, number one. Number two, one of the pieces I think that's really missing is what the effect of vaccine is in terms of modification of a course of pertussis in an individual that's been immunized and infected, but does it alter the course even if someone does come down with pertussis? And what are the ramifications of that? We were also asked to consider any or additional Tdap for at-risk populations and how that at-risk population should be defined. And is there any comment on that? Dr. Shuckett.
Yeah, maybe this is not a comment on that, but just building off of the earlier comment. I think we should be cautious about generalizing to adults right now what we're learning about performance of Tdap in teenagers, because most adults either got whole cell vaccine as children or perhaps didn't get a vaccine as children. And so the performance of Tdap and its duration of protection may not be exactly what we're seeing in the Washington teenagers who were primed with acellular vaccines. So because of our low coverage and the lack of, consistent diagnostics, I don't think we yet have great data on performance of Tdap in the adult population, which, including the duration, which might help us, reconcile which are the subsets where we should really focus beyond pregnant women. So it sort of bridges to your question just a little bit.
Thank you. Larry.
One thing about populations, when we look at vaccines, we always look at patients who have primary and secondary immune deficiency. I don't think there's any specific primary immune deficiency for which pertussis is an organism, like you see catalase-positive organisms for chronic granulomatous disease. But there are many people out there, I don't take care of adults, but pulmonary fibrosis, pulmonary hypertension, chronic obstructive pulmonary disease, if they got pertussis, they're not going to do very well. In children, cystic fibrosis is a disease they would get it. So have you thought about these specific high-risk groups where there are pulmonary or cardiovascular conditions that may predispose to death if individuals get pertussis.
Dr. Lair and then Dr. England.
Possibly a silly question. The data shows that you decrease the incidence of the disease, but does it show that you decrease the incidence of the infectiousness? So could you possibly have the disease and still be infectious? And you're nodding yes.
You can, so we're just measuring the effectiveness of vaccine against preventing disease that meets the case definition. We're not assessing whether you're infected but mildly symptomatic or infected but asymptomatic, and we're not assessing whether you're more or less likely to transmit.
Dr. England.
I'd like to represent the high-risk children for whom I care for, and first of all, for the children with underlying lung disease, they are already covered, underlying heart and lung disease, they are covered by the pediatric recommendations. I'm not going to talk about the adults. But what I would like to say is the underlying cancer, the children with cancer, immunodeficiency, transplantation, are already actually covered by many of the transplant guidelines by American Society of Transplantation and the BMT societies in terms of family vaccination, which is often one dose of Tdap, which is already included in the recommendation. So I don't think you have to add much. Perhaps we might need to be a little more explicit that immunizing family members of children or of patients who cannot respond to vaccine is recommended. But in most pediatric centers that care for kids with cancer, kids with immunodeficiency, that is routine. And they're actually good compliant people. We can get them in. Thank you.
Other discussion or questions? Was that helpful to the working group? Okay, very good. Why don't we move then along if Dr. McIntyre is ready to go?
Okay, thank you, and it's really has been a privilege being part of the ACIP working group. I've learned a lot, and one of the things I have really learned is how bright the employment prospects are in Pertussis. So I'd like to tell you about the Australian experience really with cocooning, and I'd like to acknowledge that there are a large number of people who have been involved in this work other than myself. But I thought it might be of interest to just spend a little bit of time looking at the background epidemiology of pertussis to put the Australian situation in perspective in the US before going on to look at the cocooning program and the case control study we conducted in one state of Australia, New South Wales, which interestingly has about the same population as Washington State, and then finally some of the limitations and conclusions from this work. So this is the coarsest kind of pertussis epidemiologic data. It's case counts going back to the early 1980s as reported to WHO for Canada, the UK and Northern Ireland, the US and Australia. And as you can see, the situation in 1981 was very different to what's happened over the last decade. And Australia has been ahead of the US in case counts for the last decade. And in fact, something which gave us a small amount of cheer was that our case counts have gone below the US for the first time in 2012. But I'd like to focus, because I think this is the real interest in the discussion for the last part of this session, on the cases in very young infants. And these are data that we have been able to assemble from Australia, from California and from England and Wales about these two crucial things, this time expressed as incidents, so not as just case counts, but just for young infants. So for those under 3 months in England and Wales, for those under 4 months in Australia and California, and going back more or less the last 10 years. And you can see that the incidence in this youngest group of infants is closer than the graph I showed you before, and also, you know, that although Australia is leading the pack, it's not out on its own. But If you look here at numbers, which is just individual numbers of deaths reported by year in these 3 locations over that time, again you can see that the numbers are small, and if we try and turn that into some kind of incidence summary, this is the total number of deaths in that period reported from Australia, California, England and Wales, and if you calculate that as a rate per million live births, you see that the differences that we saw in case counts and other parameters are much less, and in fact all these estimates are really compatible with each other. So that, I think, gives a little bit of perspective, in my view anyway, to what we're talking about this afternoon. And I guess in relation to cocoon strategy, we've based that, and it's happened in both the US and Australia particularly, on these sort of data. This is a meta-analysis we recently published which looked at all the studies that had examined source of infection, and that showed that parents were in these studies responsible for 50 to 60% of transmissions, and I guess it was on that basis that in Australia since 2003, not dissimilarly to the US, cocooning has been recommended as something which should happen but was not funded. But something which is also important, I think, is the uncertainty about what siblings contribute to transmission to young infants. And this, in the meta-analysis we did, was the most uncertain parameter with a very wide range, and obviously that's very important because if siblings are significant, then cocooning doesn't really have anything to offer. So in the state of New South Wales, and back in 2009, which is a long time in recent pertussis history, the only option which was available in the context of a pertussis outbreak at that time was to supplement cocooning, and the New South Wales government actually provided one of the most generous subsidised schemes, I think, anywhere. So effectively any adult who was in contact with any child under 12 months of age, not just parents of newborns, could qualify for free vaccine and would obtain that from their family practitioner. So what I'm going to talk about now is the case control study we did to evaluate the first 2 years of this experience between 2009 and 2011, and we were richly endowed with cases. We had almost 400 cases, and this is just infants under 4 months of age in the state of New South Wales. Of those, we were able to actually interview just over half of those, and we had full data available for just under 200 with full timing information and about 200 matched controls, and these controls were matched from our birth registry, so we had 3 controls per case, and all the control children were born on the same day as a case child. So we were able to very closely match access to vaccine amongst cases and controls. When we looked at the cases we couldn't contact, they were more likely to have had disease onset earlier in the 2-year period, more likely to have resided in a metropolitan area, but otherwise were very similar to the cases that we were able to contact. And so this gives you just a snapshot of the characteristics of the cases in the study. This is infant age in weeks. We only included infants up to the age of 4 months. And in the context of the enormous amount of pertussis testing that goes on in Australia, in fact, only just over 70% of the children under 5 weeks of age were hospitalised. The others were either seen in emergency departments or in some cases only seen by their family doctor. And that declined to just under 60% of cases that were hospitalised in this group, who represented about 2/3 of cases who were older than 6 weeks of age. So that, I think, reflects just how much access to testing and how much of a focus on testing there is in Australia. Okay, so these data are meant to give you an indication of, compared to the just over 400 control infants that we had up here, of whom about 80% of mothers were vaccinated, what the timing of vaccine was in this program, which was delivered by family doctors. So if you look at the proportion that were never vaccinated, that was similar in cases and controls and was just over 20%. So I said close to 80% coverage over this period in a funded program. The thing which stands out here is the the higher proportion of control mothers who reported having received the vaccine prior, and this is not just before birth but before pregnancy, because there was no vaccination in pregnancy during this period. Whereas if you look at the periods after birth, in fact what stands out is cases were more likely to be vaccinated late. And if we put this together, what we see overall is that there was this clear excess of controls who received DTPA at least 4 weeks before the onset of illness in the case, and we match the receipt of DTPA in control mothers or parents to the date of onset of pertussis in the case child. If we look at the cases within 4 weeks of onset, there was a bias towards cases, and of course after onset there were some individuals who were vaccinated as well. So if we try and summarise this descriptive data in a univariate analysis, we get this rather complicated table, but the thing which I'd like to emphasise here is that when we look just at the question of, was the mother vaccinated at any time, we found no effect. So in fact the odds ratio for pertussis in the development in the infant was 0.8 with confidence intervals really around 1. But when we focused only on the mother having been vaccinated at least 4 weeks before the onset in the case child, including before birth, we had a reduction of almost 50% that was significant. And a number of socioeconomic factors, such as not having a father who was resident in the household, being eligible for a healthcare card, having a lower education level, were all associated with higher risks of pertussis, as was larger households, and in particular households containing older children. So if a household contained any children 6 years or older, there was a threefold increase in risk in our data, and we were not able to demonstrate any independent effect of vaccinating fathers, but of course vaccination of fathers travelled along very closely with vaccination of mothers. So the other thing I guess this table gives you a flavour for is how many confounders there are in this analysis, and just how many factors are playing out in terms of development of pertussis in an individual case. And we did our best to try and control for these factors, and this is the multivariate model which we developed. The eligibility for supplemented healthcare, lower educational level, absence of breastfeeding, not having a father living in the household, and the age of your children in your household all remained in the model as significant contributors. But when we control for all those things, we find, as in the unadjusted data, that any vaccination was completely non-significant. But if we looked at the specific situation of being vaccinated at least 4 weeks before onset, we did see a reduction, and that was significant only amongst the mothers who reported having received the vaccine prior to the current pregnancy, although there were similar estimates for the whole group of those who'd received the vaccine at least 4 weeks before onset, whether it was after birth or whether it was before pregnancy. As this I thought I would show you separately. This is the adjusted data for the impact of the age of siblings in the household, and the thing we was really struck by and hadn't expected to see quite so clearly as this was that having 4 to 5 year old children in the household was not associated with any increase in risk. There was some increase, and in Australia we don't give a booster until 4 years of age after 6 months, so there was some increase associated with 2 to 3 year old children, but again this impact of older children who were 6 years and above was evident. We were only able to get validated data for the self-reported immunisation status for about 25% of cases and controls, and that's because we were required to obtain written consent and actually have that written consent returned to us before we could contact the providers. And so unfortunately that meant that we had incomplete provider data, but the data we did have suggested that there was a high degree of correlation between report of receiving vaccine at any time or receiving vaccine after birth in both cases and controls. But In relation to the report of having received vaccine before birth, we found that was somewhat unreliable in the data that we could identify, but the report of receiving the vaccine at least 4 weeks or at least 2 weeks before onset was fairly reliable amongst the controls, and if anything, the cases tended to over-report that. So I guess that would have been a bias in our data towards detecting no effect. So I guess the summary in our view, and others may differ, but in terms of the strengths of this study is that it's the largest study that's available to evaluate the impact of cocooning, and we did achieve very high coverage in the target population, which is something which I don't think has been reported elsewhere. I mean, the limitations were that we relied on self-report for timing, and so there was some misclassification that we could identify, but we think that was non-differential, and we think that by and large it would have led to more difficulty in detecting an effect rather than a bias towards detecting an effect which wasn't present. We were able, we had a number of cases that we couldn't contact, but we couldn't identify any difference between the cases that were and weren't in the study that would be likely to bias it. And of course, in terms of the now critical question of whether vaccination in a previous pregnancy might provide you with any ongoing protection, we have limited power to evaluate that, particularly given the lack of complete data on timing. Nevertheless, the conclusions that we developed from this study were, firstly, that we think this is the first evidence that, in fact, a cocoon vaccination strategy can decrease the risk of early onset pertussis, but the timing of that dose is crucial and needs to be an adequate period of time before disease in the infant. That clearly transmission to siblings in our setting is important, and equally clearly even the most successful cocoon strategy can't impact on that. And I guess we feel there is some evidence from this study which supports the notion that there may be some continued benefit despite the very much lower antibody levels that are seen a year after vaccination in later pregnancies. But to confirm this impression, we would need more data, and particularly more detailed data on timing. And given the fact that cocoon strategies were funded like this in a number of other Australian states, and there are evaluations ongoing, we think that there may well be capacity to get additional data to inform this question over the next couple of years. So thanks very much.
Thank you. Why don't we have Dr. Salisbury come up?
Well, ladies and gentlemen, good afternoon. At the October meeting of this committee, I alerted you that we had just made a recommendation to introduce pertussis vaccination for pregnant women. And so it's my pleasure to give you some of the preliminary results from the program that we started probably about a week before the 1st of October of last year. You've already seen some of our epidemiology set against some of the other country epidemiology that's been reported. This graph shows you, firstly, on the y-axis on this side, the rate per 100,000 for those 6 months and older, broken down by age group, and the y-axis over on the right-hand side shows you the rate per 100,000 for those less than 6 months of age. And the bit that stands out, I think, is that if you supplanted this against the data that we saw earlier, which indeed Peter did, our rates over the most part of that last 15-year period were very low compared with others. And it's also worth noting that we switched to a cellular pertussis in 2004. And so it may be that we are just the late catchers up of phenomena that others had seen earlier. But if you look particularly at this part of the graph, you see that there are two groups here with the highest rates. One of those groups is the group of people aged 10 to 14 years, and their rate is 25 per 100,000. and the other are the group here, less than 3 months of age, and their rate is 250 per 100,000. So the rate in those less than 6 months of age is 10 times higher than the rate in the other, the nearest high rate. And so this really told us that we needed to focus all our efforts on those youngest children and their protection, whilst we thought a little bit longer and harder about what to do with some of the other age groups. If we look now at the more recent data, and you see here by month of 2012-13, I'm sorry those are upside down, and here these are numbers of laboratory-confirmed pertussis cases by month. This is all ages, and it's for England and Wales, and the confirmation is essentially by PCR. What you see is the seasonal variation of pertussis that we are used to seeing, where cases increased over the summer and early autumn, and then they naturally decline through the winter, and then we expect to see that going up again. Now, here is where we started our program of vaccinating pregnant women, and whilst I would like to persuade you that that had some impact on the overall number of cases, that would be entirely misleading, because clearly it has no impact on the overall number of laboratory-confirmed cases. However, what I would like to try to persuade you is that we have had an impact, because this is now looking at the laboratory-confirmed cases again. The y-axis here is the number of laboratory-confirmed cases of those over 6 months of age, and over on the other side, we've got the laboratory-confirmed cases in those less than 6 months of age. And the two curves of note are these two here. This is essentially those who are 15 years and over. This is numbers, not rates. And here are the numbers in those, and here's the axis over here for those who are less than 6 months of age. And what I would like to persuade you is that the proportionate fall in those who are the youngest has been greater than the proportionate fall in any of the other age groups. Moving on then to tell you a little bit about what we did. This program, as I say, was launched in the last week of September. The first is that we recommended the vaccination of all pregnant women using Tdap IPV, because that's what we already had a very large reserve stock of. And so it was very easy for us to issue that vaccine rather than a Tdap without IPV in it. Our recommendation was that we would vaccinate all women between 28 and 38 weeks of pregnancy, and that we recommended vaccination in each and every pregnancy. To go along with the recommendation, we produced a series of materials aimed at mothers essentially, and there were a series of both leaflets, Q&A material, posters, material for healthcare professionals, and clearly we used our own Department of Health websites. One of the things that I would draw to your attention, rather than me over on the right, is this process here, where pregnant women are able to sign up to receive weekly emails or text messages or other ways of getting electronic messaging, and they receive that every week through their pregnancy and indeed subsequently after the birth of the child. And here basically, if anyone that wants to sign up, you can. I don't think it asks too much about your details, and essentially both the mother and the father are able to sign up to receive this material, and this is the purpose over on the right-hand side of what it does. Here is the male shot that comes out at 26 weeks, and at 26 weeks, everybody who signed up for this gets advised about the availability of pertussis vaccine and the recommendation that they should receive it from 28 weeks onwards. And then over on this side, you can see here is the male shot that goes at 34 weeks, and so at 34 weeks you get a further reminder about the need for whooping cough vaccination. So we have achieved pretty high awareness of this program. Starting here with the numbers of doses that we distributed, over the month of October, we distributed 200,000 doses of Tdap IPV, and the amount of vaccine thereafter stabilized at between 40 and 50,000 doses per month. At 50,000 doses per month being used, that would relate to something of the region of about 80% coverage. Here is the coverage, because in the 6 weeks that it took us to put this program together, one of the things that we did was put in place a scheme for national data collection for vaccination of pregnant women. And you can see here that we're running close to 60% coverage. And my guess is that, if anything, this is an underestimate, because this is data that's being provided essentially by midwives who may not necessarily be well connected with the data collection system, because they may not be vaccinating in exactly the same places where normal primary care data is being collected. And that would fit with this utilization data as potentially being an underestimate. So we then went to a separate sentinel system using something called the Clinical Practice Research Database, which is a sentinel system that looks at all clinical contacts for 6% of the England population. And so every contact is documented with all of the details. And from this, we were able to see that the coverage that was achieved through this system was between 80 and 70%. And so, again, comes quite close to what we were seeing through the other data collection system. So I think it is reasonable to assume that our coverage is probably in excess of 60% and probably below 80%. Having got that data allows us then to make some estimates of the effectiveness. And so, using the screening method and starting here with all of the cases that were being collected through the Clinical Practice Research Database, we discarded a Welsh case because Wales isn't included in the CPRD data set. But nevertheless, that gives us a vaccine efficacy for all cases of 89%, and if we discard the Welsh case and we discard cases where the onset was after 2 months of age, we get an efficacy of 91%. If we knock the coverage through the CPRD down by 10%, and we assume that the national system was more accurate than this, so we're taking what would be a worst case, we see that that has actually relatively little impact, bringing the efficacy down to 87%. So that now, I think, is the first data for vaccine efficacy of the vaccination of pregnant women. And we can then analyze the data a little deeper, and we can look at the efficacy according to the interval between vaccination and the onset of disease. And so where the vaccine efficacy for vaccination 28 days before birth gives us an efficacy of 90%. If we look at efficacy between 7 to 27 days before birth, we get down to 76%. And if we go down to a very narrow window of efficacy between vaccination and the onset after birth, we get down to a much lower level of efficacy. So clearly, if the mother is vaccinated at the sort of recommended time, which is between 28 and 38 weeks of pregnancy, one has a much higher prospect of achieving high efficacy with the vaccine in preventing disease in the infant. We've also been able to look at safety because the numbers now are really quite significant. And so we've again used the clinical practice research database looking at a range of predefined pregnancy-related adverse events. We had background data on the known rates of events, and so we were able to look at short-term risks using the observed versus expected analysis methodology. And you can see listed there the conditions that were studied using observed versus expected rates. And there was no increase in any of those, but particularly there was no increase in the rate of stillbirths in vaccinated women, where the study group size was around 17,000 women. For stillbirths, a second, more detailed study was done using a matched cohort approach. And so using the CPRD, there were 6,000 vaccinated women identified, and they were matched each with 3 controls from the year before who were not vaccinated. And so using this perhaps more powerful and more specific assessment, we were able to confirm that there was no increase in the rate of stillbirths following pertussis vaccination in pregnant women, nor indeed were there in any of the other studied outcomes. So in conclusion, I think this is probably the first data that shows the effectiveness of vaccination of pregnant women between 28 and 38 weeks of pregnancy. The program was put in place in something of the order of around 6 weeks. High coverage has been achieved pretty much from the outset. High vaccine efficacy up to 2 months of age has been shown, and studies on around 18,000 women give assurance of safety in pregnancy. There is an ongoing study to look at the immune responses of infants whose mothers were vaccinated during pregnancy, to look at the antibody responses to their first immunizations that are given at 2 months of age. So it's been a pleasure to be able to report our first data, and we will clearly continue monitoring very carefully over this next pertussis season to see what impact we're able to have on this group where the highest risk of disease, hospitalization, and indeed death falls. So thank you.
Thank you very much. I think we're open to questions for both Dr. Salisbury and Dr. McIntyre, and I see Dr. Vasquez.
Yes, thank you. I have a question for Dr. Salisbury. How'd you go from coverage rates of 0 to 80%? Wish we could do that. My real question is, in your vaccine effectiveness study, was previous vaccine with Tdap in the pregnant women counted as vaccinated?
There was none.
It wasn't. So
there was none. None of these women could have been vaccinated apart from, well, I don't think they could have been, because they would have not have had any vaccination with pertussis-containing vaccine since they were aged 3 years.
So there is no adult vaccination? Okay, thank you.
Dr. Campbell-Southcote.
Yeah, so my question is related. I think it's important to put this in context of what your immunization recommendations are for other age groups. And so you've kind of hinted at it, that you don't give adolescent vaccine. Okay, so these were basically naive until vaccinated in pregnancy. Now, my next question then is,
they weren't naive, they were vaccinated.
Well, I mean, as an adult. Okay, so they were vaccinated as children, yes, but not vaccinated at adolescence or as an adult.
No.
Okay. Now, so the next question is,
and I think the same for Peter.
How are you going to evaluate the...
We've had adolescent vaccination since about 2004.
So some could have been.
Oh, sorry. We have had adolescent vaccination since about 2004, and I think the question of, is it a first or second dose, but there may have been a very small number who were eligible for that, but not significant.
Okay. So the next question then is regarding the next pregnancy for repeat use and repeat, subsequent pregnancies, how are you going to assess added value of a second vaccine in a second pregnancy?
The recommendation that we made to have a further vaccination in subsequent pregnancies was based really on the very rapid decline in antibodies that were known, and we therefore assumed that if the antibodies fall as quickly as they do, we cannot presume that they will still be protected. Now, it may turn out that they do have a degree of protection in subsequent pregnancies. I think we opted for the safer choice.
So my question is, are you going to assess that, and how can you do that when you have such high rates?
Maybe I'll have to come back and answer that. I don't know the answer at this stage as to how we will tease out the effect of vaccination in the first pregnancy having a protective effect in subsequent pregnancies. If we have high coverage in subsequent pregnancies, it will be difficult.
Dr. Baker, I think you had a comment, and we'll also have a question, because I think in October you had mentioned some ongoing studies in terms of maternal antibody.
So I have one question for Dr. McIntyre and a comment. Congratulations to both of you. It almost makes me want to move, but I'm too old to leave the U.S. The ongoing study mentioned by Dr. Tempte was an NIH-funded study, a phase 1, placebo-controlled, and besides safety in the infant and mother, which I wasn't too worried about, we wanted to look at immune interference with the routine immunization schedule. The bottom line is we looked before the first dose at 2 months of age, and not surprisingly, the vaccinated women offspring had significantly higher antibodies to all the pertussis antigens. This was antenatal Adacel versus placebo, and then a crossover. If you didn't get immunized antenatally with Tdap, you got Tdap postpartum. And then looking at the infants at 7 months of age, this would be after their 3 doses at 2, 4, and 6, there was no statistically significant interference with any of the vaccines. But remember, the numbers are very small and the confidence intervals wide in these studies. And there was one, quote unquote, statistically lower in the antenatally vaccinated things, and that was for, as I recall, FHA. It was fine for the other antigens. And at 13 months, so after a 12-month, the 4th dose booster, no differences at all. So it suggested, again, in a phase 1, extremely small study. But I want to congratulate both of you. And Dr. McIntyre, I have no doubt that cocooning would work if it could be done. So can you tell me, in some way you decide, I would say, how much did it cost in New South Wales to prevent 1 case of pertussis, when you think about free vaccine, free administration, whatever? Do you have any idea what the program cost? Because you did say generous, so it must have cost something.
Yes, well, I think we do know how many vaccine doses were purchased, but I think I'd get slaughtered by the New South Wales people if I gave you a figure for that. So, but I think it's a very relevant question, and as I said, we were making this decision in 2009, and it really didn't seem like vaccination in pregnancy was an option at that point, which I guess just indicates how quickly things have moved. But if I'm allowed to ask David a question, even though I've presented, I'd like to ask 2 things. One is, which I think is a big question for maternal vaccination internationally, and that is, is it, as has been projected in the UK currently, an outbreak response, something you do when you've got lots of pertussis and then you stop doing, or does it actually become effectively the first part of your infant schedule? Dose 1 is the dose the mother gets. And because that has a whole lot of follow-on, questions which it then raises. And I guess particularly given the UK's obviously very successful accelerated schedule of 2, 3, 4 months for pertussis in infants, that clearly would be a bit more of a concern in relation to interference. And is that something which is exercising minds in the UK at the moment?
Well, before I forget, Carol, if you want a letter of support to come, I'll happily write one for you. And I'm sure age is not a discriminant feature. But to answer Peter's questions, the program was put in place as a temporary program in response to an outbreak, and there were a number of policy and political reasons why we did that, because the quickest and easiest way to get the new program in was because there was an outbreak. And in terms of the background data that would be necessary for putting in place a permanent program would have been very much greater, and we felt that the length of time it would take to do complex modeling to support a formal policy change to the program would have left us with increasing numbers of cases of pertussis, and we were responding to what we saw as a national level outbreak. So that's why we did it the way we did, and it is badged as a temporary program. We review it. It's been reviewed twice already, and the recommendations have been to continue until we have a much more certain idea of where the epidemiology is going. For exactly the reasons that you say, we are looking very carefully at the possibility of the immune responses being blunted by the maternal immunization, and we are following carefully the first vaccinated cohorts.
Dr. Schaffner.
Thank you. Schaffner from the National Foundation for Infectious Diseases. I join in the chorus of admiration for what you all have been able to do so efficiently. My question has to do with the nature of your, I gather, comprehensive electronic data management scheme, so you can track this. Can you define the practitioners who are and who are not immunizing their pregnant women? And do you have plans to provide them some continuing education and motivation to do even better?
Depends which scheme you're talking about. The 6% that are within the clinical practice research database, I mean, the compliance is very high. Well, you saw that because the coverage is between 70 and 80%. In terms of the rest of the whole country database, yes, these are databases that can be analyzed down to local level. We've got more experience, for example, with flu, about drilling down to individual practitioners and performance managing. And with our recent program for the catch-up for measles, what we've been able to do is to look at who has not ordered extra supplies of vaccine, and they get visited. Peter, can you track down who's behaving and who isn't?
Well, we know what's happening to the children, but not to the adults, unfortunately. So that's and we are actively exploring the notion that in the midwife's data, which is collected on all births, can we get receipt of flu vaccine and pertussis vaccine included in that, which is probably the most efficient way of doing it for us.
Had just also really appreciate the comments on the rapid look at safety being done in the UK. I think that's very, very helpful for us making a recommendation on very thin evidence last time around. But that being said, I appreciate that Dr. Sawyer mentioned the ongoing safety evaluation going on for this, with hopefully kind of the first pass of data coming back maybe as early as this fall. That being said, at the current rate of use in the United States, and the coverage of the vaccine safety data link, I don't think we're going to be able to accumulate more than about 4,000 cases compared to your 18,000, so we really appreciate that. I'm wondering if either Dr. Ornstein or Dr. Gillen would care to comment on some of the discussion from NVAC last week in terms of the maternal working group at NVAC and some of the issues coming up with that work group.
That was a yes/no question. I think just briefly that this is something we've put in place. In fact, it was the discussions of pertussis at NVAC a year ago that led not to a pertussis-specific working group, but a maternal immunization working group that would have broader implications. That has been in place for some time, and the twin goals were to look at current barriers to pertussis vaccination in pregnant women, and a second goal of barriers to development of other vaccines that are designed for maternal immunization, specifically those that would be designed for the benefit more of the newborn than the mother. So those are that's what the working group is working on. There's a process in place, and they will, I don't have the recommendations in front of me, we can get you, but they'll have a final vote on recommendations on that first goal in September. But at the same time, and Vito may want to comment on this, the ACCV advises on the compensation program, and also had a group that was focused on maternal immunizations that was looking at a similar set of issues through the lens of the ACCV. So without any specifics, and we can get you where those recommendations are, I think the message is that from the advisory committee perspective, there are 2 federal advisory committees on vaccines that are seriously trying to take a look at how we improve maternal immunization now, and the opportunities for the development of vaccines for maternal immunization in the future. But Walt and Vita may want to add to that.
Yeah, I don't really have anything more other than basically this initial focus on how we improve, including issues of how we use pregnancy vaccination as performance quality measures, how we train people and work with people to adopt pregnancy vaccination. And Laura Riley may want to comment from the ACOG perspective, since they've been doing quite a bit of work to try to improve immunization practices among obstetricians.
Dr. Riley.
Thank you for the opportunity. So I actually have a question for Dr. Salisbury. I mean, our method of healthcare delivery is completely different. I was happy to see that it looked like much of your campaign was directly to pregnant women. We did include in the toolkit that we presented this morning, there is a whole thing on Text for Baby, and we're hoping that through Text for Baby, for those of you who don't know, Text for Baby does push out those messages about get your flu vaccination, get your pertussis vaccination, or ask about pertussis. It's interesting. I kind of feel like we have much more pushback from our patients, and as much as we want to educate providers, which we definitely want to do, the other half of that equation is what will patients go for. And just anecdotally, I've found, interestingly enough, pregnant women seem to be willing to get the pertussis vaccine the first time around. And I'm actually getting pushback from women who got pertussis, say, 2 years ago when we were doing postpartum pertussis. Those women are saying, really, I have to be vaccinated again, and show me the data, and are you sure it's safe, and sort of a much more extensive discussion. So I'm happy to see what you have there, because it'll be a little bit easier to make the argument, but the way we practice is significantly different, and I wonder how much of that plays into how poorly we're doing.
Dr. Shuckett.
Yeah, just a comment that I think the perception of risk of disease really changes attitudes during pregnancy, and I think in the UK this program was launched in the context of an emergency response. We saw in the VSD data that in California they had significantly higher coverage in 2011 following the epidemic disease in that state in 2010. So because 49 of the states had a lot of disease this past year at the time of our recommendation, perhaps we will be doing a little bit better, in this first year. But I think, Laura, your question of will it be sustained for second pregnancies in the UK, will there be continued interest after that perception of this as new and concerning goes away? On the other hand, we were very heartened that influenza vaccination coverage in pregnancy really increased during the pandemic, or in the wake of the pandemic, and has sustained at a higher level since then. It didn't go right back to 15% after that. So I think we just need to really consistently work on this, but I wouldn't be too pessimistic yet.
I think just one other comment too is I still see a lot of pushback from clinicians out there who are providing obstetric care, and not only from OB-GYN but also in family medicine and so on. And I think there needs to be a lot of education. I think I just realized actually at the last NVAC meeting that in fact when we made the recommendation for Tdap in pregnancy the first time around, it was a real paradigm shift for this committee, because it's the first time we made a recommendation for reduction of illness not in the vaccine recipient but in a secondary party, i.e. the fetus. And I don't think you can make the same argument for influenza, but influenza you're immunizing for the pregnant woman. Here you're primarily doing it for protection of the newborn. But that being said, I think, Dr. Baker.
John, we all know that we don't make the diagnosis of pertussis in adults, so we don't know anything about the burden of disease in pregnant women. And until we have active surveillance, I would debate that there may, if you have bad pertussis as a pregnant woman in the first trimester, for example, there may be an increase. We don't have any data. The other thing is, and this is an area where we need a lot more research, but if you do surveys of actively pregnant women, okay, you're pregnant right now, you're carrying a baby. The biggest single, this won't surprise Larry Pickering, the biggest single influencer is the recommendation of your obstetrical care provider. And, we're working in a primarily Hispanic, very socioeconomically deprived kind of population. If somebody talks to them about having pertussis immunization during pregnancy, we have a 96% compliance. Those data are in press, they're not out yet. So I think our biggest barrier is provider, not patient. Laura works in Boston, and I think probably at the Brigham has some very intelligent people, and the more intelligence and education you have, the more likely you are to be vaccine refusing. We know that from pediatric studies. So it may not be true in every circumstance, but I think people sell pregnant women short. They need the encouragement to hear the data and get the education, so that's great, they're going to get the education, but if their health care provider doesn't recommend flu or pertussis immunization, they're not going to get it.
Thank you, Dr. Baker. Is it Dr. Paradiso?
Yes.
At the
yes.
back? And then we have Ms. Hayes.
Peter Paradiso. This is for Dr. Salisbury as well. Were you surprised, or maybe I'll just say I was surprised, 90% efficacy with passive transfer of pertussis antibody to babies is better than the efficacy we've seen in active immunization in almost all age groups. And so it's a pretty astounding number and very nice to see. And if I calculate correctly, you should see a 50 to 70% reduction in disease in kids under 6 months of age coming into this summer season. And I think that would pretty clearly verify the efficacy rates that you've said. And just to add on to that, two comments. The one is that being able to claim 90% efficacy or anything near that, I think will probably help a lot in convincing providers that this vaccine is worth doing and getting it used in the United States. And the second, which is more of a question, are you going to look at antibody levels? You said you were going to look at kids coming back and getting vaccinated. Are you going to look at how much antibody was passively transferred and try to get some correlation between those efficacy values and how much antibody? Getting back to Dr. Plotkin's comment earlier about trying to understand what protection is.
The study, as far as I'm aware, basically is bleeding the children when they come for their first immunization at 2 months, so it won't correlate with antibodies transplacentally acquired at the time of birth. But I agree with you, the efficacy was extremely high.
And Ms. Hayes.
Carol Hayes here. Today I'm representing the American Nurses Association, but I'm a nurse midwife and I practice here in the metropolitan Atlanta area, and I work in a high-risk perinatology practice, and when I ask every pregnant woman if their obstetrician has offered them a vaccine, every single one of them, 100% says no.
So additional testimony to Dr. Baker's comments about the education really needs to go out to the clinicians out there. Dr. Bennett.
Yeah, just a comment. I think this is like every other vaccine we look at, and we really need to build it into our system and not be dependent on the provider offering it, but rather have it be, when a woman shows up to get her prenatal care, that this is part of what she gets, regardless of whether the provider remembers or not.
Additional comments, or shall we let Dr. Bennett have the last word? Thanks again to Dr. McIntyre and Dr. Salisbury for wonderful and an uplifting talk there after the pessimism of the cost effectiveness. And with that, I think we're on for a break. Also, I'd just like to mention very quickly that there are two travel alerts out there, one for travel to Poland and the second for travel to Japan due to outbreaks of rubella. And those are up on the screen.